So thanks for having us. So this is going to be part 2 of our series, piggybacking off of what we spoke about last week. Today we're going to be talking about arterial lines as well as thoracentesis and paracentesis. We once again have no conflicts of interest to disclose. So just to kind of repeat the objectives, so just pretty much like what we spoke about, review indications, contraindications, and techniques to undergo ultrasound-guided arterial lines, as well as describe the use of ultrasound for both paracentesis and thoracentesis. So we'll continue with a case, a 6-month-old, previously healthy male who presented to the ED with 5 days of URI symptoms. In the ED, he was known to be tachycardic as well as hypoxic, was placed on high flow and then rapidly intubated for progressing respiratory failure, transferred to the PICU with an IO on an epinephrine drip with sets in the 80s on high FiO2. So we'll talk about, based on this case, indications and contraindications for placement of an arterial line. I think overall, the trend that I've noticed is that we're going a little bit away from putting arterial lines in all of our intubated patients. I think if you look back years ago, that's kind of how was the practice. Now we tend to do it less frequently. So indications, so continuous blood pressure monitoring. So anyone really on like a cardipine drip or some sort of antihypertensive medication where you want frequent blood pressure monitoring, or vice versa if they're on epinephrine or another vasoactive medication. Frequent arterial sampling, so if you want frequent blood gases, monitoring of your PaO2, as well as it's indicated for patients with TBI and elevated ICP. So when you're trying to target specific serial perfusion pressures, it helps you precisely target those. And overall, ultrasound in general, so you can do these without ultrasound, but ultrasound is particularly helpful with patients who are in shock with thready pulses, or they're on ECMO with a non-pulsatile flow. They're edematous, where it's hard to really feel the artery. They're obese, as well as significant hypotension. All of our contraindications are more or less relative contraindications. So typically, we know that anyone who's coagulopathic or on anticoagulation will increase your risk of bleeding. If you already have an extremity with compromised perfusion, it's probably best that you don't go put your arterial line in that extremity if you can avoid it, as well as an area with overlying skin infection or tissue compromise. So kind of what I brought up in the beginning, why use ultrasound for arterial lines if you can just feel the pulse and kind of go after it. This is a Cochrane review based on from last year that was published, showing that it pretty much showed that increased first attempt success was noted with ultrasound. And then they broke it down both into radial arterial line and femoral arterial line, and even for both of those, it increased your first attempt success. Overall, it took less time to do the procedure when you're using ultrasound versus just palpating. And I mean, overall, we can say this Cochrane review also showed that in patients, neonates and children less than 4 years of age, it's more likely to be helpful than our older patients above 4, because the artery at that point is bigger, it's a larger target, and often easier to palpate pulses. So definitely for sure in the younger kids, it definitely shows benefit. And then they also looked at novice users versus more experienced ultrasound users. So even it did still favor use of ultrasound in the novice user as well as the experienced user, even when they broke those apart. And then lastly, it led to fewer complications with ultrasound versus not. So I think this pretty much overall shows that we should really be using ultrasound for our arterial lines. We went through this last time, so briefly we'll be using our high frequency linear transducer to find the vein versus artery. So our vein is typically the more circular, fully compressible, and changes in size with respiratory variation, versus your artery is more circularly shaped, thick-walled, and pulsatile, and you should have a hard time fully compressing it. So it's obviously always important to figure out which is vein versus artery. So the similar steps is when we talk about doing central line. So prior to the procedure, you want to use ultrasound to identify your baseline anatomy. So you always want to evaluate the patency of your vessels, any anatomic abnormalities. You want to confirm adequate perfusion collateral. So if you're doing a radial arterial line, performing the Allen's test is one way you can confirm collaterals. But you can also be using your ultrasound to look both at your radial and ulnar arteries. You want to measure the size of your vessel to try and understand the appropriate size catheter to use. Typically, in my practice, typically 2.5 to 3 French catheters peripherally, and sometimes a little bit bigger if you're going centrally, depending on the size of the patient. But you always want to measure the vessel because some kids can have smaller vessels where you want to target a smaller size arterial line. You want to look for your safest needle insertion site. So you want to look for an area where there's an absence of thrombus. Thrombus in your artery is a little bit rarer to see compared to your vein. You want to look to see where your artery is largest in size. Typically make your target a little bit bigger. And then you want to make sure you kind of understand your underlying anatomy and try and stay away from your nerves so that you're not causing any nerve injury. So this is just visualization. So this is not live images, but in figure A, we can see your radial artery in pretty much the center of your screen in short axis and then long axis below in letter D. You can use color Doppler if you want to confirm that it's arterial. So you can see that color Doppler can be used in both the short and long axis. And then you can also utilize pulse wave Doppler in the last images on the side to confirm that you do have arterial variation, which you can see pulsatility on the pulse wave Doppler as well. So these are the typical most common locations that we think about putting in arterial lines. So most commonly is the radial artery. It's a nice and straight artery, pretty superficial, close to the skin. So often this is the most targeted artery, followed by, you can also peripherally, you can also put in the dorsalis pedis or posterior tibial artery, which are both found in the foot. And those are really the 3 peripheral locations that we look at. Often your complication risk is less if you're going to go peripherally. So if the patient allows it, it's best to do this peripherally. When you need to put in a central arterial catheter, your femoral artery and your axillary artery are your 2 big options. You run into a little bit higher risk because these don't have significant collaterals. So you do worry about if like you develop a clot or large hematoma compromised to that extremity. And however, in situations where patients really clamp down or they're in shock, it's often can be difficult to get a peripheral arterial line in the amount of time that you want, so you can go straight centrally. The axillary artery, you also could get concerned about injury to the brachial plexus in the area, especially if a hematoma develops, you can have compression of your brachial plexus. So this is just some ultrasound images of your upper extremity vessels. So your brachial artery runs at the top of your extremity proximally. You can see in that first box. That's where your brachial artery you would find. It runs very close to your median nerve. So if you do target, which I don't routinely go after the brachial artery, you have to make sure your median nerve is directly next to it. And then moving down the arm, you can see the radial artery is pretty close to your radial nerve proximally, but as you go more distally towards the wrist, it separates out a little bit, and that's typically the most common site that we go after for radial arterial lines. The ulnar artery and ulnar nerve run pretty close next to each other too, so we typically favor the radial over the ulnar, and it's often bigger. These are the vessels of your arterial vessels of your leg. So starting proximally, you can see our common femoral artery, which is in between your femoral vein and femoral nerve. As you go lower down, you can see the bifurcation of your common femoral into your superficial femoral artery and deep femoral artery. And typically we would want to put in our arterial line proximal to that bifurcation. And then as you move further down the leg, it's just showing us images of your dorsalis pedis as well as your posterior tibial arteries. So similar approach to your central line, you always want to do everything sterilely, and you always want to use real-time guidance of your ultrasound to visualize puncture of the artery and the needle inside the artery. Positioning, like we spoke about last time, is important. So you always want to position yourself in line with the patient, in line with the ultrasound, so that you're not looking over your shoulder while trying to kind of work in your field. It's often more successful to have everything in a nice straight line. So we'll talk briefly about some of the techniques. So you can do this in short axis or long axis. When we typically short axis is the way most people have done it, and it's typically the way that you train first. So this is a image. It's hard to see here, but you can see on the top right of your screen, you can see kind of the needle in your radial artery there. Not the best image, but just to give you an idea of how you know that you're within your artery. And then you can also do longitudinal axis, which is just rotating your probe 90 degrees. But for this, you can visualize your needle going directly into your vessel of choice. However, you need to be careful to make sure that you're lined up properly and that you don't get off axis, because you can either get into the wrong vessel or have trouble. So once you confirm that your tip is centrally located within the artery and there's blood return, you advance the guide wire without resistance. Hopefully, you should be able to advance it without resistance. If you are hitting resistance, you always want to try and reposition your needle and reevaluate with ultrasound to make sure that you haven't slipped out of your vessel. And we'll talk a little bit about the different possibilities there in the coming slides, which is right here. So these are some reasons for failure. So in A here, we can see we have our artery, we have our needle inside the artery, nicely in the center. You're getting good blood return. This is like the ideal position needle. And then when you look at B, this is when you go into the vessel, you're partially in the vessel, partially not in the vessel. So you are still getting blood coming back, but any kind of slight movement, you could be out of the vessel. And then when you try and put your wire in, if you're not fully in the vessel, you're not going to be able to get into the vessel. So this can be one reason that you're seeing good blood return, but not actually able to advance your wire. For letter C here, is kind of the opposite. So now you're back walled. So you're all the way up against the back wall of your vessel. So as you try and put your wire through, you're just hitting the back wall of the vessel. So in this situation, you can pull back, or you can drop your needle a little bit more towards the skin to be on less of an angle. And in D here, this needle is positioned perfectly. However, sometimes the vessel can undergo vasospasm. So even though you're in the perfect position, you still have trouble advancing your wire. So there's other techniques so some people like to do it different ways. The most common from what I've seen is the needle followed by the wire and then the catheter. This you can also do. This is just an angiocath, similar to placing an IV. You go in, you have your IV, your needle in the center of the vessel, and then you just advance your catheter into the artery. Some people prefer this and think that it's easier. I think a lot of it is how you've trained and what you're used to. For this is an example of one of the kind of all-in-one cannulation kits. So these exist where you have your needle, your wire, and your catheter kind of all in one device. So what you do is you go in with your needle. When you get like blood flash, you advance your wire in, and then you advance your catheter. So it's an all-in-one device. You don't have to like pull out and constantly exchange things. Some people also prefer this, and I think a lot of it depends on what you're comfortable with and what you've trained with. This is just a study on the older side that looked at direct cannulation versus modified Seldinger technique, and pretty much what it showed is that overall the modified Seldinger technique has less attempts, less amount of time, less risk of hematoma. But I mean, I think that a lot of this is what you're used to. So if this group is people who are used to the Seldinger technique and who are now undergoing direct cannulation, I think that can be a little bit of bias to the study. So I think a lot of it is, like I said, is what you've trained and what you're used to doing.
All right. So moving away from vessels, some of the same techniques apply. I'm going to go through thoracentesis and chest tube placement. This is one where I think there's a lot of variability of whether people use ultrasound or not, but hopefully we'll go through some data that will show you that there is support for it and that there are some pretty good reasons to try to invoke ultrasound in your chest tube placements. So going back to our 6-month-old baby, he is now in severe hypoxemic respiratory failure. He now has the CVL and art lines that you placed as you previously discussed. He's still only saturating about 87% on 96% FiO2. So you go ahead and you grab your ultrasound to try to take a peek. What you see is some fluid on the right side. So you're going to go ahead and move towards a thoracentesis, but actually you're going to leave a chest tube in because you think this kid is sick enough it might reaccumulate. So when you're thinking about thoracentesis and chest tube placement, I think in the PICU, most of the time, we're going to leave a chest tube in just because of our patient's physiology. There are times where a thoracentesis is the right answer. I had a patient recently who was post-operative. He was very fluid overloaded from that post-op period, but he didn't really have ongoing lung disease and really just needed that fluid evacuated so his lung could re-expand. So in that situation, a thoracentesis was a reasonable option for him. No chest tube really needed to stay in place. Indications for either of these procedures is effusion. So whether that's empyema, whether that's simple fluid, whether that's, reactive fluid to an infection, and also pneumothorax, pardon the typo there. So either air or liquid, something needs to get out of the cavity. Again, when you're thinking about contraindications, these are all relative. Sometimes your patient needs the procedure no matter what the risks are. You just have to weigh those really carefully. Coagulopathy and anticoagulation certainly increase your risk of hemorrhage. I think there are ways to mitigate this with various products and timing of things like platelets or FFP. And again, just being careful about where you are. And we'll talk about how ultrasound can help mitigate that risk. Again, if you have an overlying skin infection or integrity issues, you may need to think about, is there a better site to do this? But you may also not have a choice of where the right position is for your patient. So going to the basics, you're going to use the same probe as you do really for your vascular access. So the high frequency linear array probe, whether that is a hockey stick or just a linear probe. You can also use a phased array probe, which gives you a little bit more depth, a little less resolution, depending on where you are scanning and how the patient's size relates to that. I typically use the hockey stick on most of my small patients and then the linear probe in my larger patients. The phased array also does work. It's just a matter of which footprint fits better into your hand and which fits better in your patient's physiology. Trying to get between the ribs or trying to kind of see between the ribs can be tricky in patients of different size. So I recommend always using a couple, kind of trying to see where you get your best setup. Going back to our basic ultrasound physics, obviously dense tissues are the needle, you're going to see your bones, and you're going to see your pleura, and those are all going to be bright white. So those are hyperechoic, and then your fluid-filled structures are going to be hypoechoic. And that is what that looks like, right? So on the right-hand side of this picture, you have the spleen, which gives you a nice window. Here you can see you have some lung, and then here you have a dark spot that is fluid, and that is your pleural effusion. So that would be your target for your intervention. Here is a video of that. Let's see if I can get it to play. So here you can, on the right, you can see that there's some diaphragm reflecting up. You can see that there is some lung kind of flapping in the breeze here, or flapping in the fluid here. And you can see the dark space above that indicates that there's some fluid there that would be amenable to probable drainage. So positioning for your patient, obviously the positioning is no different than it is for a standard chest tube or thoracentesis. You still want to be going for that kind of triangle of safety, and hopefully we can make it safer with the use of ultrasound. So you're going to have your patient positioned with your arm up as much as possible. If it's a smaller human, I will sometimes have somebody hold or tape it or kind of position the patient as much as I can to really open up that space. You're going to look for that fifth intercostal, and you're going to look for the triangle kind of above it to really narrow yourself down. You're going to identify that space. You're going to watch through respiratory cycles. So I put my ultrasound kind of in that general area. I watch through several respiratory cycles and make sure that my diaphragm is not creeping upwards into that space. It's always amazing to me how high the diaphragm actually gets and how small the lung windows can be in some of our kids. So just watching, making sure that your diaphragm is not coming up into the space where you're about to stick a needle. Then you're going to want to scroll through and look for your intercostal artery. This obviously runs along the ribs, and it's something that we're taught to watch for or know that it exists so that you can avoid it. And here we can actually see it. Then you're going to go move on to your procedure. You're going to prep your skin in a sterile fashion, go through your procedure through the typical Seldinger technique, and then you're going to confirm your intrapleural placement, either with ultrasound and or chest x-ray, depending on your local practice. Here's what that looks like as far as confirmation of placement on ultrasound. This is a little hard to see, but you're looking longitudinally here, and you can see that there is a hyperechoic structure. It's hard to get the pointer and to get this to run at the same time, but you can see here that there is some hyperechoic line there that indicates that is where your catheter is. As with most ultrasound, this is much easier in real time when you can kind of follow things and track things and make sure that you can really like trace your catheter from the insertion site into the lung. So how does ultrasound help? If this procedure is one that most people, perform without ultrasound, why would we go ahead and add ultrasound to the mix? I think there's always people who, just like with arterial lines or central lines, I've done it for years. Why would I use this new technology? Well, this is a study from 2003. It was in chest, and this was looking at comparing the choice of sites from regular physician landmark-based choice, comparing it with looking at that with ultrasonography, and then determining if that site was accurate or not. So in the first top part of the graph, you can see that for 67%, they chose a puncture site. The physician said, this is where I would like to go. They then ultrasounded. 57% of those were accurate. They didn't have any additional risks that might be unexpected. However, in about 10% of them, that site was inaccurate. Either it wasn't the place where the fluid was, there was actually no fluid in about 17 of those 25 cases, which I thought was really interesting. There were places where the lung was much more opposed to the body wall and would have been at risk, making actually injury to the lung and potentially invoking trauma. And then the liver and the spleen were actually present in about 12 of those sites, which I thought was really interesting because, again, we assume that organs are where we think they are in our patients' bodies, but sometimes those cavities are a lot smaller and a lot more compressed. They also did the opposite, where there was no site. The physician said, you know what, there's not really a great site here that I can identify. Again, using ultrasound, they were able to actually identify sites in about 20% of those patients. So if there was no landmark-based opportunity, ultrasound was able to identify some. Sorry, guys, my mouse is freaking out. There we go. Sorry about that. Again, there's been reviews of these studies because I think pulling the small studies together is always really helpful. This was a set of 24 studies that actually pulled together about a little over 6,000 thoracenteses. If you look on the bottom, this is looking at proportions. The top section is with ultrasound, and then the bottom section is without ultrasound. And this is looking at the proportion of thoracenteses that had complications of pneumothorax. So you can see on the bottom with no ultrasonography used that the proportion of procedures that had pneumothorax was to the right and it had higher proportion, whereas ultrasound was on the left. So ultrasound was correlated with less pneumothorax in the procedures where it was utilized. This was significant in the testing that they did. And again, this was about 6,700 procedures. So this is a large data set. Again, looking at your identification of your space, you're trying to avoid these blood vessels, right? So you have blood vessels that are kind of running along the ribs, and we assume, right, that they're in the same position for every patient, but we know that that's just not true. So when you're looking at patients and when they scan a large number of patients, it seems like actually when you measure along, sorry, this pointer does not want to cooperate. So when you kind of measure your way along, this as you go more laterally, so from medial to lateral, where we think that artery usually is kind of under the rib above you, it actually isn't. So as you move more towards the lateral side, the fraction that's actually there is less and less. So I thought that was really interesting that, where we assume these vessels to be in a safe, cozy spot isn't always the case. So again, just kind of highlighting these studies. So there was using ultrasound and thoracentesis, improved identification of the space, improved avoidance of organs, much less trauma to the spleen or the liver, much less trauma to vessels. There was decreased pneumothoraces, increased volume removed. So they were actually able to get better pockets of fluid by targeting their ultrasound and therefore their catheter placement into an area where there was bigger pockets of fluid. And there was more accurate confirmation of the tube location, and they didn't have to wait for chest x-ray, and they didn't have to travel for things like fluoroscopy for repositioning of their lines, which is a huge both time saver, patient safety factor, because you're sitting there, you finally have your dressing on, you're not having to wait for somebody to come x-ray it and then potentially readjust your tube, and you don't have to take the patient off the unit if not necessary. Moving on to paracentesis. So this is a very similar procedure to me as thoracentesis, right? You're using a needle and or a catheter to get fluid out of a potential space that's now filled with space. So here we're going to flip to a new patient. This is a 5-year-old girl who has nephrotic syndrome, came in with acute abdominal distension, had lots of abdominal pain. She had fevers. She's febrile to 40.1, tachycardic diaphoretic, abdominal distension, and she's in respiratory distress. So you go ahead and grab your ultrasound. You take a look at your lungs, and your lungs look okay. There's no identified pathology there. But because of her respiratory distress and because of her large abdomen, you go ahead and take a look, and you notice that there's fluid. So because of the impending respiratory failure, you go ahead and perform an ultrasound-assisted paracentesis. The probe that I usually use here, again, depends on the patient size. It can be really any of the probes. I have probably most commonly used my curvilinear or my phased array, but the linear and the hockey stick probes also will work, particularly in a smaller patient. Here, you're really not looking for like the entire view of the abdomen. You do want to sweep through the entire abdomen and find all the organs and make sure you have a sense of where your fluid is. But one of the primary things that I'll show you is you're looking on the surface for where the vessels are that you're trying to avoid with your needle sticks. So sometimes a combination of each of these probes will get you the information that you need. So general indications for paracentesis, typically they fall into 2 categories, either diagnostic, such as in this patient, we're maybe looking for infection, so we're going to send some fluid. We may be trying to see if this is a reactive or an exudative or what this fluid is. Is it blood? Is it something else? And it can be therapeutic. So we can improve our lung compliance, improve patient comfort, and at some points, just promote that ongoing healing by getting the fluid out of the space. There's really no absolute contraindications. You want to be cautious in anybody with a coagulopathy, DIC. Organomegaly certainly makes this more complicated, but again, ultrasound hopefully makes that less of a risk as you're identifying your features as you go in. If someone's had multiple prior abdominal surgeries, you really want to be careful. Things like adhesions are not going to be very easily visible, even on ultrasound. So you need to be careful that you could be getting into a bit of a hostile abdomen and making sure that you have a backup plan for that. And then you want to just be careful if you have an ileus or someone with severe constipation, if the bowel is not going to be as mobile or maybe not in the same place as you would expect it to be because of its distension and displacement. So the last thing you want to do is go ahead and stick a needle into a bowel and cause any sort of perforation, no matter how small it may be. So just being thoughtful about what the insides of your patient's abdomen might look like. Going back to your abdominal wall anatomy, pulling a picture out of Netter from back in our med school days. So you can see here kind of going from lateral to medial. You have your inferior epigastric artery that runs on the either side of your umbilicus and kind of under your recti muscles. And then you have a more lateral, deep circumflex iliac artery that's going to be more lateral. So one of our main jobs in doing this procedure is that we are avoiding those vessels. You also, again, have the musculature. So your rectus muscles are nice, solid muscles. They run strongly through the middle of your abdomen. And then there's areas where they're a little bit thinner. So you can use ultrasound to help identify that. So what you're going to do here is go ahead and identify your safe acoustic pocket. So you're going to use your probe and look for where the fluid is. How much fluid is there and where is it? So you're going to use your standard abdominal views. Here they're using a phased array probe, looking in the gutters behind the kidney. You're going and looking in the pelvis to see if your fluid is lower and kind of around the bladder or in the lower abdomen. And then on the upper right-hand side, they're again looking in the other, this is on the left side of the patient, looking around the stomach and behind the spleen. You can see on this bottom right-hand image, this is what the image you're going to get looks like. So these little red stars identify where the fluid is. Again, fluid is dark. It's still dark in every image that we take. You can see that the white is different organs, and we're not getting a great view of the abdominal wall here. This is the picture more for depth, looking at your intestines and other large structures that you'd want to avoid. This is just another view of that. So again, in the middle you have B, this is for bladder. The other pockets of fluid are potential ascites or hematoma or whatever your fluid may be. So those would be potential targets for drainage. And then flipping your probe to a new site, again, on the right-hand side, again, you just see more pockets of fluid that would be amenable to your drainage. Looking for your vessels is a really important part of this, because the last thing you want to do is stick a needle right through an artery when it could have very easily been avoided. When you're not using ultrasound, you're using your basic anatomy skills to remember where those should be. But again, not every patient reads the textbook. So using Doppler ultrasound can be really valuable here. So here you can see a picture. This is using a shorter, I believe, linear probe to really see the abdominal wall. You can see the bowel underlying in the bottom left corner. And in the nice little box, they're using color Doppler to identify their veins and arteries. So you can see that where you might have gone in the middle of this image, if you have this in front of you, then you can move your needle based on the muscle body. I probably would even go a little bit more to the left just to minimize going through the body of a muscle. But this really allows you to get around those vessels and make sure you're not causing any damage. Once you've identified your area where you want to stick, I usually will mark with a pen just to make sure as the patient moves, but also remember that as you mark, the patient's internal organs will move as well. So you want to make sure that you're rescanning on a regular basis and not doing this in just a one and done fashion. Typically put the patient's head of bed up to about 30 degrees. If they'll tolerate that, you prep your skin in your usual sterile fashion. You're going to use your sterile probe cover. And cover your transducer. And then again, right before you're about to stick for your procedure, you're going to go ahead and rescan and make sure that things haven't floated around. Remember, your intestines are, especially with fluid in your abdomen, moving around quite frequently. So you want to make sure that the site that was safe 5 minutes ago is still safe. And then you go ahead and complete your procedure. I think these are all things that we've talked about. So avoiding things like surgical scars, avoiding areas of cellulitis, trying to avoid the bodies of your recti. If you can, if your fluid is globally distributed, trying to go on the left side more than the right side, because the cecum is more adherent and a little bit more attached. So that means the intestine on that side is a little less free flowing. Again, you want to try to use your dynamic ultrasound as much as possible. So not just a static mark of this is where is a safe spot, but really following that needle tip in the same procedure as you would through your vascular access that we've talked about several times. So following that needle tip, advancing your needle, advancing your probe, advancing your needle, advancing your probe, and just making sure that you are safely moving into that abdominal cavity. If you're going to place a drain, going through the Seldinger technique in the same fashion, using a wire, taking out the wire and then placing your drain, and then connecting that via IV tubing, usually to a drainage bag of some sort, or a drainage atrium similar to a chest tube setup, something that will hold the volume. So what are the benefits here? How do we say that ultrasound is really the right thing? These are mostly adult studies. The number of paracenteses done in adults is significantly higher than that in children, mostly driven, I think, by some of the patients with cirrhosis who get multiple paracenteses over time. Here, this is looking at the risk of bleeding complications. And you can see all patients at the top And when ultrasound guidance was used, that risk dropped down to 0.27%. So that was much lower than the 1.25% of patients who did not use ultrasound guidance in their procedures. And this is actually a study from 2013. So this has been being studied in the adult world for quite some time. Excuse me. They actually went through and readjusted this. So they adjusted for inpatient and outpatient status, their admitting diagnosis, the day of the procedure. And really the thing that came through was that ultrasound was one of the biggest factors in the adjustment that decreased the rate of complications surrounding bleeding. In a patient with cirrhosis, that's a really big deal because not wanting to volume load them, not wanting to give them donor exposures if they might be transplant candidates. So avoiding any sort of bleeding in that patient population is really helpful. Here is a ultrasound video clip of what this looks like. So you'll be able to see the needle coming in on your left side of your screen. So you can see there is liver edge to the bottom left. You've got your pocket of fluid. Here you can see you've got some free floating, probably intestinal wall in here, or maybe some debris. And then you've got your needle coming in on the upper left. And then you can see that that will be in the appropriate position. So these are procedures that, again, I think many of us do central access, arterial access on a really regular basis. Paracentesis and thoracentesis maybe a little less commonly, although if your units are anything like ours, we've been doing chest tubes left and right this winter. It seems like everyone has an empyema. So trying to encourage people to use ultrasound to remind them that it does have value and that you can make your patients' procedures more safe and more efficient, and just reminding them that this is a tool that has been studied and with use comes comfort.